So in the overview for antidepressants, one of the things that was mentioned and that had come up in discussion was that there are some gender differences that we see. This goes beyond just the SSRIs, but for the sake of time, trying to keep this to a didactic blitz, I tried to focus just on the SSRIs, although I do have a little bit of teaser information here a little bit later on. First things first, though, as a disclaimer, there are, most of this information is looking at individuals with their biologically assigned genders, and there are some generalizations that are going to be made, recognizing this doesn't hold true for absolutely everyone of that biologically assigned gender, but just something to keep in mind. So our objectives, we're going to look at the proposed mechanisms that might result in a difference in the SSRI efficacy between males and females. And we're going to then take a quick look at some of the efficacy that compares the SSRIs when we're looking at males and females. So ultimately, is there a difference? That's the question we're trying to answer today. If we give patients who are this is focused mainly on depression, those that are depressed in SSRI, can we expect something different between the two? The answer is maybe, and I'll tell you why. So to start with, there is a difference in depression and gender overall. So the graph on the left-hand side is the lifetime risk of depression. And this data is a couple years old, but overall the lifetime risk of depression was 21% in females compared to 13% in males. So we did see an increased risk. That risk presented itself just after puberty. Individuals that are children, they tended to have a little bit more of a similar risk. The severity of symptoms when individuals present with depression tend to be more severe in women. They often are reported to have increased anxiety. They may have more atypical depression where they are eating, their appetite is increased, their sleeping is increased, and they're more likely to report some of the physical manifestations that come along with depression. It also has been reported that prolonged episodes of depression and recurrence of depression seems to happen more frequently in women, although there are some discrepancies depending on the population that you look at. But that this is a disease that tends to go on for a long time and may show up a little bit more frequently. Women sometimes, women are more likely to have a younger onset of disease. So when they first start having symptoms or are diagnosed, they tend to be a little bit younger than what we see in males. And there tends to be a larger impact on quality of life. And again, this is a little bit inconsistent in the literature depending on what you look at, and in some cases it may be quality of life just because of the demands that sometimes are put on women, especially in the realm of home plus employment, and if there are other family issues, so especially older parents, having a number of those demands on them may be what impacts the quality of life. It may not be the depression in general, but there are some reports that that could happen. So recognizing there might be a little bit of a difference in the disease state itself does skew our perspective slightly. So if we're going to treat them, is there something that would be better for one over the other? And it has been reported that the SSRIs are more beneficial for women than for men. Slightly, maybe not, I'm going to argue maybe not so much clinically significant, but some of the factors that contribute to that, there's a multitude of them. This is just a quick snapshot. We're going to look at those that are pharmacokinetic, so what the body does to the drug. We're going to look at some of the physiologic effects, but there's two on here that I'm going to cover on this slide and not necessarily get back to in general. One is adherence. So if a patient has depression and is put on an antidepressant, their first line, about 2/3 of those patients tend to do better. But they do better if they're taking their medication. If they're not taking the medication, then that may not improve their outcomes overall. There are some discrepancies in adherence. We actually see that younger men tended to have a little bit better adherence initially. As we get a little bit older, more toward mid to late 40s into the 50s, so perimenopausal, postmenopausal women, we see an improvement in their adherence and a decrease in the adherence of men. So we can see some differences between the genders with that. Does that have the full impact on the efficacy? Probably not. In fact, most patients that are prescribed an antidepressant don't continue to take it. There's prescription abandonment that happens very quickly within 2 to 3 months for almost half of patients. But something to keep in mind that might be one of the differences. Another big difference that can drive some of the changes that we see is adverse effect profile. So there have been some reports that female patients tend to have a greater burden of adverse effects. So maybe not necessarily that they have more of the adverse effects than men, but that it impacts them more significantly. And that may be one of the reasons that they don't tolerate some of the other medications quite as well, things like the tricyclic antidepressants or our monoamine oxidase inhibitors. On the flip side, women are also much more likely to experience weight gain when they're on antidepressants. And that's been specifically quantified with the SSRIs. So we see significantly more weight gain in women than in men. And sexual dysfunction tends to be a little bit more broad in women than in men. So we can see things such as decrease in libido, as well as decrease in arousal and problems with orgasm in women, where we don't tend to see as frequently the broad impact on sexual function in men. It definitely still can happen, but it seems overall that that burden tends to be reported more frequently in women. So let's take a quick look at these other factors that might impact how well the antidepressants work for each of these genders. And as I mentioned, I broke it down in pharmacokinetic, so what the body does to the drug, as well as the physiologic factors. So on the pharmacokinetic side, there are a few things, features that are different in women than in men that could impact their ability to absorb the drug, to get the drug into the body so it can work in the brain, the ability to process it and then eliminate it. So on the absorption side, women can have decreased gastric acid compared to men. That may mean that it may be more difficult for them to break down certain medications. The SSRIs in general don't tend to be really acid specific in their absorption. Most of them are well absorbed regardless of whether or not they eat, but it might have a little bit of an impact. They also can have slowed gastric motility, especially at certain parts of the menstrual cycle. So that may mean that the drug will actually stay in the intestines for a longer period of time. That may allow a female to absorb more of the drug just because it's hanging out in the intestines for a longer period of time. Now, we don't always see higher concentrations, but it may be that just a little bit of a boost might make a difference. On the distribution side, this was what I guess spurred me to put the disclaimer up there. Men tend to have a lower percent of adipose tissue. So women tend to have much more fat tissue. The antidepressants are lipophilic. They like the fat tissue. So they're much more likely to distribute into all of that fat tissue. So yes, it'll get into the brain, but it will also get into all of the other adipose reserves in the body. That may mean that the concentrations that go into the brain may be slightly different for women over men. Now, this would suggest that maybe men with the smaller volume of distribution will get more into the brain, but potentially it also allows the drug to hang out for a little bit longer because it's in some of those fat pockets. Other factors, metabolism. So there is a slight difference in metabolism activity of these enzymes between men and women. So 3A4, we tend to have faster clearance in women than in men. 2D6 and 1A2, we see faster clearance in men than in women. Now, this is laboratory faster. Does that have clinical impact? It doesn't seem to. So there aren't necessarily different dosing guidelines. It seems that even when patients are given substrates of each of these, they reach about the same serum concentrations. So it's not that women are burning through something and there's almost nothing there compared to men, but maybe it's another contributing factor that when we add everything into the mix might make a difference. And then on the excretion side, they do tend to have slower gastric motility. So if there is fecal removal, excretion, that might be a little bit slower than what we would see in men. And then this just gives you, purely for reference, looking at that distribution, where that might be an impact. The metabolism, as you see, quite a few of these antidepressants use those enzymes that do have some gender differences. And on the excretion side, with the exception of fluvoxamine, citalopram, escitalopram, and fluoxetine are reported to have urinary excretion, but it's less than 20% of the dose. So I wasn't able to completely find all of the percentages for how else it gets eliminated. It could be processed through the skin, it could be breathed out, it could be fecal. So yes, it's mainly urinary, but that's probably not the full story. So there are differences between men and women and how they process the medication. There's also just general differences in how men and women, the activity that they have with a number of the neurotransmitters, specifically with the monoamines. So in this case, we're talking about dopamine, norepinephrine, and serotonin. So we can see both changes in increases and decreases in norepinephrine or dopamine in women compared to men. In some cases, the increase may actually make that pathway less responsive. So there's too much dopamine activity, and it means that they essentially downregulate some of those receptors, and it's not as responsive a network. And that may play a role. There look to be an increased number of serotonin transporters and a change in the affinity of a number of the serotonin receptors. So what this may do is that in women, they may not necessarily have the same set point for each of these neurotransmitters that we believe to play a role in depression. There also are changes in each of these systems as patients age. So sometimes we see a much bigger or a much smaller change in these systems in men compared to women, which overall, if they are involved with depression, could potentially impact their response to medications long term. The other big thing, which I kind of alluded to a little bit there with the age difference, is estrogen. So estrogen's role in neuroplasticity. So estrogen definitely plays a role in some of the neurotrophic factors, so some of the chemicals that help keep the neurons healthy. It also can stimulate some of the spines on the neurons, so some of the extra connections that we can see between the neurons. So we want the neurons to continue to grow and develop and network so that it can be healthy. And sometimes the estrogen may play a role in either kind of going haywire, maybe it's developing in an area that's causing some of the symptoms, or potentially there's not enough there and we're starting to see some increased symptomatology because of that. So there may be some inherent differences that make it more or less likely that women would respond to some of our antidepressants. So recognizing there are all of these factors that can play a role in response to males and females with depression, does this actually result in any differences in efficacy? So there's more literature than what I included. I just tried to give you a snapshot. So this first trial was conducted in the late 90s. It was outpatients who more than half of them had previously been hospitalized with depression, but they all had at least dysthymia and were enrolled in a mood disorders program. Most of them were in their early 30s. There was a small number, and of the 42 that were in this program, 35 of them were treated with fluoxetine, 5 of them were treated with tricyclics, and 2 of them were treated with an MAOI. And as they went back and looked at how the patients were doing, they found that 85% of the women who were given fluoxetine were considered responders. And in this case, response was on the global assessment of functioning, So the scale that goes 1 to 100, most of us tend to be at the higher end, so between 80 and 100. So they were just looking at those patients being above 70 as their response. And they saw 85% of the women on fluoxetine were able to achieve that, and less than half, so 47% of the men. When they looked at the tricyclic group, there were slightly more men. 58% of them were considered responders compared to 45% of the women. But statistically, those numbers were pretty low, and they didn't do an analysis to see if there was a difference there. So this suggested that maybe there was a difference between responses in the genders. Our STAR-D trial, which was one of the largest outpatient trials for depression, also looked at gender differences. So these were adult patients with major depressive disorder. They were on citalopram, and they could be titrated from 20 milligrams to 60 milligrams. They were on this medication and followed for approximately 12 to 14 weeks. And depending on whether or not they responded, they were then continued, added another treatment, or switched to something different. So this was really just that first phase. Their response criteria were a Hamilton Depression Rating Score of 7 or less, and then the quick inventory of depressive symptomatology, the self-report, that scale of 5 or less. So that scale, if you're not familiar, goes from 1 to 27. So 5 essentially being that there are no symptoms at all. 6 to 10 was mild symptoms. When they looked at all of the data for these patients, what they found was the number of patients who went into remission was significantly higher for the women, 29% compared to 24%. Not for remission of the quick inventory, but response, so that there was a 50% decrease. They saw a bigger response in women than in men. So this suggested again that maybe there is a difference, recognizing again it was only 12 to 14 weeks between the genders. There have been subsequent trials that don't, so there's a couple other trials, some that look at sertraline, some that look at fluvoxamine that suggest the same thing. But when we have a couple meta-analyses, some of them do not find the same finding. So this was just one of them. So this looked at 9 different trials, over 1,700 adults. All of the adults had major depressive disorder. They were treated in the trials with either fluoxetine, a tricyclic, in this case it was disipramine or imipramine, or an MAOI. So they looked at the data from all 9 of these trials, and they evaluated, is there a difference in men versus women? And is there a difference in older versus younger? And in this case, they used 50 years as the cutoff. They looked at responses at 50, 52, 54, and 56 years, and found that 50 was really seemed to be the difference between the two. So that was why they established that. The average age of menopause for the patients that were included was about 47. In this case, they included response as the clinical global impression. So they needed a CGI score of 1 or 2, so very much improved or much improved. So it's a little bit small, but hopefully you can see the top 2 charts. It's the percent without a response to tricyclics. The red line is women, the blue line is men. On the left, it's patients under 50, and on the right, it's patients over 50. The middle one are the MAOIs, and then the bottom one is the fluoxetine. In each of these categories, there's very little difference between the 2 genders. We see a little bit of separation with the tricyclics, where potentially more of the women, more of the men were not considered responders. And then the same with the younger of the MAOIs, but not a statistically significant difference in either of those categories. So that really drew into question, and there have been subsequent trials that also don't see a difference. Maybe there's not that much of a difference. If we do enough analyses, then maybe we'll come up with something that's significant, even if it's not actually significant, that there's not a difference. As people have gone back to look at this to try to answer the question, is there or isn't there a difference? they found that there are a number of variables that really could impact us being able to answer this. One is the diagnostic criteria. So in some cases, well, just over time, the DSM-3, 4, and 5 had slightly different criteria for depression. Also, the trials included what they call double depression, so major depressive disorder with dysthymia. Some included atypical depression, some did not include atypical depression. So they had a lot of variability within the diagnostic criteria of the patients who are involved. And that could play a role in whether or not we see a difference. The overall demographics of the population, how old were these patients? It appears that for the women who respond best to the SSRIs, they're premenopausal or perimenopausal. So they still have quite a bit of that estrogen going around. Other factors that could potentially play a role there are what other supports do they have? How long have they had the illness? In some cases, the trials were done in patients who had been sick for 2 or 3 decades. That may make them less likely to respond to some of the antidepressants that they're using in the trials. The measurements, so I gave you 3 different trials, and you saw a variety of measurement tools that were used to identify whether or not the patients were responding or had remitted to depression. So that could be a big difference. If we're looking at a specific checklist like the Hamilton Depression Rating Scale or the Montgomery-Asbury Depression Rating Scale, that may be very different than just saying the CGI. Yes, they look better, they look improved or very much improved. So that also is a discrepancy. The duration of treatment, the vast majority of those trials included in the meta-analysis were 6 weeks or less. So I believe that there was 1 open label trial that was 8 weeks. So that's significantly less time. That may be barely enough time to see if there's going to be improvement in the patients on antidepressants. And some of them addressed adherence and some of them did not. So if we don't know if they were actually taking the medication, it's hard to be able to say that, yes, this had an improvement or not. So quite a few things that muddy the waters. So to try to put that all together, there have been reported differences in the genders, with women responding better to the SSRIs, potentially men responding better to the tricyclic antidepressants. And there's a number of factors, both the way the body processes the medication as well as just physiologic factors themselves, that seem to suggest that, yeah, maybe there would be a difference between men and women. It's inconsistent though. If we look at the clinical data, it really is inconsistent on whether or not there is a difference. And even if there is, it doesn't look like the difference is significant, is truly clinically significant. So in some cases, the improvement in remission was 4 percentage points. So you're looking at still about a quarter, less than 30% of those patients were in remission. That's really not the goal of therapy that we want. We're looking to have everybody improve. So something to keep in mind with your patients, but it may not necessarily be the driver for your decision making. And with that,